So the next speaker in this session is Dr. Rupam Borgohain. Sir is currently working as a consultant in City Neurocenter, Hyderabad. He will be discussing about deep brain stimulation for dystonia, the Indian scenario currently.
Thank you very much. First of all, I'd like to thank all of you, Kufik and Prashant, for calling me for this talk. Now, it's a little off the Botox because we've been doing Botox for a donkey's number of years, 40 years, sorry. So I said we need to do something a little different. And he said, do the writer's cramp. I said, it's been a long time, so we need to do something a little different. So this goes on like this. DBS for dystonia was first done in 1977. You see it being used for primary generalized dystonia, segmental dystonia, cervical myoclonus, no problem. There are no specific guidelines. That is the very funny thing. We have guidelines for everything else, but for dystonia, you can do it. 7 years and older. Generally, strictly speaking, the only guideline we follow is if it's a focal dystonia, I can give Botox and get away with it. Stick to Botox. Not responding to Botox, disease spreads to other parts, go for it. If you have a metabolic disorder with segmental or generalized involvement, Botox is going to cost too much, go for DBS. So, what's the role of genetics? There have been actually a meta-analysis done as late as April last year. You had 91 cases. Best was obviously TOR1, which had a very good response. Not so good response, rapid onset dystonia Parkinsonism. So this was a patient who's been Botoxed far too much. Actually, he was from Saudi Arabia and they were Botoxing him practically every other month.
Get your head straight as much as possible and walk back. Take out that bed.
He ended up with a problem that he was not responding, and this was his situation the day after surgery. Actually, it's worse than this. His clonic movements had come down. His clonic movements had come down. This was him about a week later, and this was him about 3 months later. So the improvement can be quite dramatic in patients with severe cervical dystonia, and they get better, and it can be very satisfying. So that's what this patient, I had Botox for about 15 years, and he slowly stopped responding. The response time came down from 6 months to 3 months, and he started having painful movements, neck movements. This became very painful, and he said, do something. So I said, okay, the next course is, according to protocol, is getting DBS done. We did the DBS, GPI, and you can see within a day, his movements had come down. The clonic movements went off, then came the tonic movements also came down, and this is him currently, and so he's very happy. So the pain also comes down, movements also come down. Why we don't do DBS for everybody? Mainly the cost. Otherwise, I don't think the efficacy is all that bad if you get it right. Of course, it's not as good, it's not as reproducible. Some patients don't respond all that well. This is one patient to case. She had very severe dystonia, cervical dystonia, and it was quite horrifying to see her. This is how she used to go. And after surgery, she got better, but it is not really persistent. We need to see whether we can do better with the programming. This is now 3 months, and initially she responded well, and this is her condition before surgery. So this can be quite horrifying. Botox can be quite expensive. So you need to think of other things to do. This, on the other hand, was a TOR1 primary dystonia. Father also had cervical dystonia, but father said, I can afford only one patient's DBS. So he said, do it for my daughter. We did his daughter. She got much better. This is her about a year after surgery. So she's gone much better, and she's attending school, doing everything else. She need to do it for the father right now. This is a patient who had KMT2B, primary dystonia. He actually came with a very odd dystonia in the sense that his dystonia was very markedly levodopa responsive. And he had a F-dopa scan which was actually positive. He also had a KMT2B gene positive, but this was variant of unknown specificity. So we were left at this state. This was on and off before surgery, and post-op he got better. So we also took out the GPI in him because of this reason. Bilateral GPI was done, and this was him before surgery. Marked dystonia. Afterwards, this improved considerably. He's not 100% better. He still has difficulty. He's still on a low dose of levodopa to take care of this, and we are really not sure where we are exactly, but he's better. So on the whole, this was his F-DOPA scan. So where do you actually fit him in can sometimes be difficult when you have a picture of both dystonia as well as Parkinsonism and genes which contribute to either. So this on the other hand was a lady who had a very marked cramptochromia. And this was actually Parkinson's disease. We didn't do the genetics. She couldn't afford it, but her cramptochromia was very marked. And just to show you that, I'll just show you this. And after surgery, the cramptochromia got much better. So you can get that as an unintended benefit of a GPI DBS also. This was what she was like before. As you can see, very marked, difficulty in walking, very difficult, and a lot of difficulty in moving. And this was her in the on state. That was off, and the on was not significantly better, but this was a cramptochromia. And this is her, something like a couple of months after surgery. So it's a remarkable improvement. You are actually treating the Parkinson's. Parkinson's got much better. The cramptochromia also improved. When we started off DBS for patients with Parkinson's disease, we were told if your patient has got any axial symptoms, whether it's walking, gait problems on and off, or whether it's a dystonia, axial dystonia and all that, they're supposed to be contraindications. But now we see all of them responding. So I don't think there's any red lines drawn, and with time, things change. So we need to be aware of that and be optimistic about the whole thing when you're going at it. But stay within your guidelines of sticking to Botox in the segmentals and the focals. If rarely, when they start getting worse, then you do this. This is another patient who had actually cervical dystonia I was injecting for. She also had truncal dystonia. Injected for about 7 years. And she had got her genetics done. KMT2B came positive because she was young onset. We did a bilateral GPI and she got better. But before surgery, she was like this. Quite a bit of cervical dystonia, quite a bit of this thing, truncal dystonia, and post-surgery, you saw the video, she's much better. She has a little bit of focal dystonia of the leg, but most of the neck problem has settled down, the trunk problem has settled down, and she's quite happy about it. So it is not 100%, but you're close there and quite good enough. So what have we got now? We have reports in India from few case reports. These are all over the world, there are only few case reports. You don't have huge series of dystonias being published anywhere. You have meta-analysis done who have collated all the data, like the first one I showed you, 235 cases, all collated case reports. It's not one center doing humongous numbers. There are some centers doing that, but by and large, most of the people concentrate on Parkinson's disease and a few dystonia cases, which is what we all do. This is published by Rupa Rajan from AIMS, and they've done this patient of KMT2B, and she's one of the first publications on this. Where the patient had a 30% improvement in the cervical dystonia scores, truncal and cervical dystonia scores with improvement in gait and getting better in ambulation. Now, the question is, we also have published some. This is a Kupffer-Jakob ATP13A2 gene, and this was the very first report, Kupffer-Jakob done, DBS done in the world. We took the GPI. Why did we go for the GPI? Because though the patient had Parkinsonism, which was levodopa responsive, the problem was that his MoCA score was very low. It was only 7/30. Strictly speaking, he shouldn't be doing this, but his Parkinsonism was quite levodopa responsive, and his actually the MRI showed global cerebral and cerebellar atrophy, and this was the patient. The Sanger sequencing showed positivity, so this was declared as a detected homozygous patient for Kupffer-Jakob. The mutation was confirmed by Sanger sequencing. And this was the patient when we were testing him in the lab, in the outpatient. And, I'm just trying to get it on. And after surgery, he got better. The scores came down. His score came down from something like 79 to 48 in the off and something like 30 or so to about 20 in the on score. The tremor, dystonia and gait got much better, and his LEDD also reduced quite a bit, came down to 400 milligram. He stopped his amantadine and long-acting levodopa, which he was on. This was published. We also have a couple of patients. We've done 3-4 patients of PANC2, and this is the basic seen in India per se. Every center has a few cases published of PANC2 and others, which cases have been done. We have not actually got together and collated the data, which I think needs to be done. What is your scene in Sri Chitra? How many patients have you done of dystrophy? Maybe 10, 15 overall? Yeah, I think everybody's done about that much. So, and basically we try to avoid doing it as much as possible. If you can get away with Botox with the segmental and focal, yes. Except when you get stuck with the other end of the 15 years, 20 years of Botoxing, and then you do this. So this lady had this girl had a very bad jaw dystonia. The hand was very badly bent. She got better. She was able to walk after surgery, but this was transient, not too long. I think it lasted for about a year or two. So to say that everything gets better in all the patients with secondary dystonia is not on. This other patient was a 24-year lady with PANC2 again, and she had this very badly, was been Botoxing her for quite some time, both the hands and the legs. She had a severe degree of pain. And it was actually the pain which forced us to go for DBS. We said, okay, we'll do it. Generally, we were not doing it because our first experience we did about 15 years back of NBI, and the patient worsened after 2 years. And it's very disheartening when you really can't do anything and the patient worsens and dies in front of you. The family is depressed, you are depressed, because most of the patients with DBS actually get better and stay better, so you're in a reasonable frame of mind. You do lose them in the end, but by and large, they're much better. So this was the girl, a lady, and she was quite happy, able to walk alone, do other things on her own, and slowly she worsened after time. Now, what about this patient? This patient was another defined gene positive. This was VPS 13C. He had generalized, this was his degree of dystonia, very marked, very severe, and he was totally incapacitated. He couldn't do anything for the last 2 years. We did the GPI, and he had a remarkable improvement, and in fact, this remarkable improvement even persists now, 2 years after surgery. He's doing everything. So, you can get them better. You get your targeting right. GPI needs very good targeting. It's supposed to be much easier than STN. We've been doing STN since time immemorial. So for us, STN is very easy to do. GPI is not so, because we have not got the hang of it. We haven't done so many, but we are doing it now. And we're getting reproducible results. So we're quite confident that if we do it, we'll get reasonable results. This needs a good team. You need to be very sure where your electrodes are. The surgeons will leave it there and tell you you're in the right place and you'll be struggling for the rest of your life. But if you don't get it in the right place, you're going to be in trouble. So DBS is not done lightly in patients with dystonia. Results are very good, but you need to do it properly. This patient was actually my patient with deafness dystonia syndrome. At that point of time, he was a deaf, mute guy who had actually done his graduation, but he was having writer's cramp. So I was injecting his writer's cramp. He got better with his writer's cramp, but 2 years down the line in COVID, it spread to his neck, it spread to his back, then it spread to his leg. And this was with pain. So he was having dystonia of all this. We did his genes. It came positive for ACT. I am never able to pronounce these. So ACTB gene came positive. It was a rare case of dystonia deafness syndrome. There have only been about 8 cases who have undergone DBS for this. We had done this quite some time back. And this patient, after surgery, we published this, but in our local journal, this is what he is. Within a day or two, he actually got remarkably better and stayed better. So this is the same person who had very marked disease. He is actually capable of working, though he is deaf mute, but he's passed his exams, and that's how he is. So dystonia can be done well. And I think the best ones are the ones in green here, you can see. Basically, it's TOR1, it's tyrosine hydroxylase involvement. THAP is not so good. Some places they say it's good, other places they say it's not so good. And TAF1 is not good compared to others. The ones which are really bad is the rapid onset dystonia Parkinsonism. The response is very poor. The sarcoglycanopathies do respond well, so it's worth doing there in those patients too. Others we go as we learn, we do this. There is significant benefit, as you can see, and non-DYT1 patients still respond. The secondary dystonias, some of them respond, most cervical dystonias respond, and this is a patient where we ended up doing 2 electrodes. He actually had anterocollis, and the anterocollis was very difficult to inject. I was injecting him for about 10 years. And every time you step up the dose for anterocollis, this is about 2 decades back, I was doing for 10 years. He used to have swallowing difficulties, so he wouldn't like it too much. Finally, I actually showed him to Kailash also. He also injected him, but he wasn't happy. So ultimately, much against my wish, I said, we'll do a DBS. So that time we were doing the STN, so I said, we'll do the STN. We did the STN, he was all right for 5 years. Then he worsened. Then we got stuck. Now what? So we did the GPI in addition to that. So this gentleman ended up with 2 implants because we are stuck. We really were stuck. It's not that we want to do 2 and show that we are a hero and all that. This is the only patient we've done 2. We did the GPI also. It's not very easy to put the GPI because of the caps. One was a little off. But what was very interesting was when he turned on the STN, his dystonia changed. This is his normal cervical dystonia. You can see this. This is his normal cervical dystonia, which he used to get in the sleep also. Regular nodding sort of movements, anterior collis, and painful. Because of this dystonic movement for 2 decades, his cervical spine had gone. He got a cervical laminectomy done with rods put in because he was developing a myelopathy. He also had cardiac stents, bypass done. So he had undergone a lot of surgeries. And after this DBS, what he actually developed was this. STN you turn on, he develops lower limb dyskinesias. He develops a little less, sorry, my battery is running lower, thank you. I hope it lasts till the end of this. So he develops a little, the head became better, the neck became better, but he has little dyskinetic movements which were actually induced by the STN. And to control that, you put on the GPI. This same strategy has been used in a recent publication, 6 patients of PD, where they've done both ST and GPI, and they found the STN response gives much better improvement, but to control the extreme effects of STN dyskinesia, they are using the GPI. In PD patients, it's published in the brain. And what they said very clearly, that this is a strategy which you can use. Doesn't mean that we go around putting double implants in everybody. That would be crazy. But this is a strategy which, why I was doing this was I was seeing that there's a distinct difference between the dyskinetic movements induced by the STN and what was happening with the dystonia per se. It is a problem, not easy to do this. And this is him with 4 electrodes in the head, laminectomy, and you can see the hardware. He's got an awful lot of hardware, and this is not done out of choice. So you need to be very careful, not do it too much. So these are some of this is the 10 cases of dystonia that was presented by, I'm getting off. This is done by the Niman's group. They published 10 cases. I think that's the last one. And basically STN versus GPI, this is the only one which has been done in meta-analysis. They looked at 319 GPI patients and 113 STN DBS patients of the GPI, STN versus 319, and they found the results are more or less similar. What they found was the best results were seen in the patients with focal dystonia. The segmental and generalized were less, and the segmental was did show some scores which were better. But by and large, movement and disability scores were improved in all. So you do need to decide what you want. But basically, at the end of all this, final conclusion is coming to the point that the GPI, DBS, which was the gold standard, and the results of the STN may be more or less the same. We need to look at this very clearly. One thing is very clear. In the PD patients, the STN is definitely more effective in efficacy. But because of side effects, because of fine-tuning, Americans may be less inclined for that, but the rest of the world is actually doing much more of STN compared to the GPI because of the efficacy, the ability to bring down the drugs. So that applies to that. So I think this is a patient we did. He also had writer's cramp, spread to the neck, spread to the other parts. We did his DBS about 15 years back. He had, we did the GPI in him. And this is him post DBS. He now has 2 kids. He's spent the last 10 years of his life working well. This is another teacher who we did the STN DBS. He had very severe painful generalized dystonia. He was a teacher. And this is him after 1 year of surgery. This is STNG. And this is him. He's been working for the last 15 years. He has some dystonia a little bit.
Go back.
Up and while, but by and large, he is fine. So both the targets, you can get good results. Depends on how well you get it done. So I think I can stop here. The take-home is that, message is that for all types, you've got to improve the patient. I think that's what we're all here for. Thank you.
For Parkinson, if they develop dyskinesia because of little programming, is that an indication to do GPI now?
Not at all. I'm not at all advocating. Actually what I do for them is I put them on sulfonamide go up to 150, even sometimes 200. And that takes control of their dyskinesias. Or you can add amentrol. Amentrol, the problem is it takes out the brain.
Yeah.
Cognitive and hallucinations. Safenamide doesn't do that, but it does control the dyskinesias.
Agree, sir.
Sir, what's your experience in secondary dystonias, like post-encephalitic GPI?
Not so good. Not so good. I'm not a very strong this thing. We have done a few. And I'm not really sure that all those, what you call as post-encephalitic are all that, or they are not metabolic, because we haven't done the genetics. So, because some of them have that same acute course, fever precipitating, and they turn out to be positive for
And
the
when the pre-op MRI is showing a lesion
yeah,
in
I
the
know,
GPI,
bilateral.
then
You
you
can-
avoid such cases?
We don't avoid it. It's a question of finance. It's not easy to get the money. Even if you suggest it, they don't get it done in most cases. Very few of the patients actually get it done. So, if you can convince them, you can always try. Tell them very clearly that the improvement is going to be a little less. It's not going to be as much as that. Thank you.